Hello, and thanks for joining us on today's webinar. This will be a presentation about the Quality Payment Program, and we are joined by Dr. Gregory Nicola, the chair of the ACR MACRA Committee. And I will hand it over to Dr. Nicola.
Thanks, Zach. I want to thank everyone for joining us for this important topic. The title of the talk is A New Value-Based Payment Paradigms, Implication for the Practicing Radiologist. But in all honesty, everyone wants to hear about MACRA, and this will be almost solely about MACRA. I have no financial disclosures. Well, I am a pessimist. That is one disclosure. However, I do have some data now to support my pessimism, especially when it comes to MACRA. Medscape in September released an online survey in which 90% of physicians either had limited or no knowledge of MACRA or MIPS. And certainly this webinar is hopes that most of the radiology community is educated into this landmark legislation. So I'm going to talk to you today, everything I'm going to talk about is from the final rule about MACRA. And when I talk about rulemaking cycles, I realize that a lot of the audience doesn't even understand what that means. So I just want to talk to you a little bit about how this works. When a healthcare law is passed, such as MACRA, which was passed in April of 2015, subsequently, what happens is that Medicare has to form a set of rules around that law. The law itself is about 95 pages. Medicare took about a year to form a set of proposed rules, rules which could be changed based on stakeholder comments. Those proposed rules were released in about April of 2016 and were open to comments, and the proposed rule is about 962 pages long. Comments were received, and Medicare adjusted the actual rules to fit the comments to make sure there wasn't any serious problems with the program. And then they published the final rule in October of this year. Just so you know, this rulemaking cycle is seen throughout many of Medicare's programs, including the physician fee schedule, the HOPS, and inpatient prospective payment system. And in MACRA, it will be a yearly rule. We'll be seeing this rulemaking cycle with a proposed rule, comments, and then final rule every year. And the ACR will be making comments to make sure our membership is protected and understands the program. The MACRA committee, of which I'm chair of, has been making comments on these rules and been deeply involved in the rulemaking process. Now, one thing I noticed in the final rule when I received it in October is I always flip to the last page of these rules to see what I'm in for, and immediately I was alarmed, and I'll highlight why I was alarmed. And that's because it was 2,398 pages. And what that meant to me is that there were certainly a lot of comments. In fact, we learned subsequently there was over 4,000 stakeholder comments on this rule. But there was going to be a lot of nuances in this process. So how did we get here? How did we get from going to medical school and learning to practice medicine to all of a sudden having to practice medicine with almost a 2,400 page document telling us what we're doing wrong and how we need to practice differently? Well, there's been a lot of alarms in the healthcare market in the United States. One of the most vocal and landmark alarms was in 2001 when the Institute of Medicine released the Crossing the Quality Chiasm report. Basically, it determined that the U.S. healthcare system did not provide consistent, high-quality care to all people. This has subsequently been proven out in several different studies, including by the OECD and Commonwealth, in which they ranked quality of care amongst 11 industrialized nations. And the U.S. basically ranked last out of all these 11 nations in quality of care. And we've all seen this. This is the cost of care as a percent of GDP. And the U.S. is much higher than all the other industrialized countries. To put this in perspective, 17% of the U.S. GDP would make the U.S. healthcare economy the 5th largest world economy, U.S. being the largest economy in the world, followed by China, Japan, Germany, and then the U.S. healthcare economy. So it's a massive amount of money being spent on keeping our population healthy. What does this mean to radiology? Well, we're always been in the crosshairs and will continue to be in the crosshairs. I will point to the last two lines here I would like you to all take a look at. One is the OECD median for the number of CT, MR, and PET scanners and the number of scans done on patients. And the second from the bottom is the United States average. And you can see we're basically double in almost all the categories compared to the OECD average for all these. Meaning, in essence, that we're doing a lot more imaging than most other countries, except for maybe Japan. So what did legislators start to do about this problem? In fact, the process started in 2006 with the legislation, the Tax Relief and Healthcare Act of 2006. In this act, Medicare established a physician quality reporting system. And I'm subsequently going to go through two other laws that will form the foundation of CMS quality program. So it'll be 3 laws in total that will form the backbone of CMS quality payment program. The first is this, and the physician quality reporting system was almost fairly a silly system in which if you had a patient encounter and it was deemed to be associated with a quality metric, you had to report that it was associated with quality metric. You actually didn't have to do the quality metric or perform on the quality metric. All you had to do was report that the encounter you had was associated with a quality metric. Subsequently, in 2009, there was the passage of the Tax Relief and Healthcare Act. I'm sorry, in 2009 was the passage of the American Recovery and Reinvestment Act. In the American Recovery and Reinvestment Act, there was a sub-act called the Health Information Technology Act, which established a meaningful use program. If you think about it, this is to promote the adoption of certified electronic health records technology. At the time, most of the country was on paper charts, either in the hospital or in the office setting. This made it very difficult to collect and compare quality measures, collect and compare cost measures, and to exchange information between offices to provide the best care for our patients. So in this legislation, it was encouraged through an incentive program to adopt electronic health records. So that's the second quality program Medicare established, the legislators established. And finally, this culminated in the introduction of the value modifier program, which was actually part of the Affordable Care Act. Most people know many parts of the Affordable Care Act, but they forget about the value modifier. What the value modifier is the first thing it did is, remember when I talked to you that the PQRS program was just a reporting rate? Well, value modifier now actually asked you to perform on that measure, and value modifier would measure you on how well you perform. In addition, the value modifier also had a collection of cost measures that you didn't actually have to submit data to Medicare. Just as long as you submitted a bill, Medicare could calculate how efficient your care was based on the indications and the encounters that you were billing. And there were a collection of cost measures that I'll talk about a few a little bit later in this talk. Another entity that came out of the Affordable Care Act was the CMS Innovation Center. The CMS Innovation Center was tasked with producing payment models that would alter the way we perform care. Instead of being volume-based, it would be value-based care. And they were granted $10 billion by the Affordable Care Act. Subsequently, they've had 3 rounds of grant releases for a total of about $3 billion so far out of the 10. And we know some of the programs that came out of this. For example, the Bundled Payment for Care Improvement Initiative, the Pioneer ACO model, the shared saving models have all come out of the Innovation Center. So to kind of summarize this, in January of 2015, the Health and Human Service Secretary, Sylvia Burwell, published a landmark article in the New England Journal of Medicine in which she stated that Medicare wanted to move its payment model to 90% of payment by 2018 would be tied to one of these quality programs I just mentioned, or all these quality programs I just mentioned: physician quality reporting system, the value modifier, and meaningful use. Or you could receive payments through APMs, and they wanted 50% of the country to be receiving payments by 2018. And in essence, this is a summary of what was happening in the healthcare market, but it's also going to form the backbone of MACRA, as you will see in just a bit. There was one issue here. With all this change and all these mandates on the clinical community on how they had to alter their care, the one thing we was faced with is that we had unstable physician fee schedule payments. And this has to do with legislation from 1997. The Balanced Budget Act of 1997 actually mandated that the physician fee schedule inflationary rate could not outpace the inflationary rate of GDP. And this sounded like a good idea at first, but when you start thinking about it with the aging baby boomer population, the marked increase in innovation in medicine and precision medicine and the cost of that to come, and also if you're an economist, Baumol's cost health disease, taking those into fact, this was doomed to fail. And sure enough, over the last decade, this formula mandated draconian cuts to physician fee schedule on the order of 30%, creating quite a bit of instability making it very difficult to transition to value-based models. Just so you know, this SGR formula, the sustainable rate formula, required a yearly patches called temporary doc fixes. A lot of these patches came with pay-fors, and many of the pay-fors were from radiology, so this was a particularly toxic formula. Well, here we have it. In April 2015, the 44th President of the United States, Barack Obama, signing into legislation the permanent doc fix to stabilize our fee schedule permanently. And you may all now know this as the Medicare Access and CHIP Reauthorization Act of 2015, or MACRA. So the very first thing, and probably the most important thing that MACRA did, is it stabilized our fee schedule. It basically repealed this SGR methodology of calculating our fee schedule, allowing us to have stable payments. The second thing it did, those 3 quality programs I just described to you, well, they happened to be formed under different sittings of Congress. They had fragmented rules, they weren't necessarily interrelated, and they had some redundancies. So what MACRA did is it looked at that, it consolidated these 3 programs into one and renamed them the Merit-Based Incentive Payment System and got rid of some of these redundancies and cleaned up the rules. This Merit-Based Incentive Payment System is now referred to by MIPS, and you might hear that term quite a bit during this talk. So there we have it, exactly what Secretary Burwell told us in the New England Journal of Medicine. MACRA wants us to be paid either through MIPS or they're going to encourage APM, these alternative payment models. That being said, the definition of APMs was quite strict under MACRA, and they had certain criteria that had to be met in order to be called to be benefited by this APM program. These criteria range from having certain thresholds of the number of patients or how much dollar amount you receive through that APM as opposed to other mechanisms of payment like fee-for-service or MIPS as a clinician. It also had to do with the type of model. It turned out not all the innovation center models met this APM criteria, and so that they couldn't be treated in the same fashion. We learned that Medicare has now renamed this entire program Quality Payment Program, or the QPP. We also learned that these models of APMs that didn't quite fit the definition, or clinicians who are in the right model but not receiving the correct threshold amounts of payments or patients, are somewhere in between. And I'll go through the in-between pathways when I go through the APM section. So here we have it is just kind of a pictorial overview of how the legislative body thinks of our current fee schedule. We have fee-for-service. They think MIPS is an improvement over fee-for-service, and that APMs is an improvement over MIPS, and subsequently they'd like most of the country receiving payments through APM. In fact, fee-for-service is now being referred to as a legacy payment system. When does this program take effect? Well, the actual date where there'll be adjustments in our income will be January 1st of 2019. But as you can imagine, in order to have an adjustment, you have to have data on a clinician. And how most of these CMS quality programs work is that there's a look-back period. And in this case, it was proposed and finalized to be a look-back period of 2 years. And the performance program, the year that you're going to perform for the adjustments in 2019, will be January 1st, 2017, which at the time of this recording is just a little over 6 weeks away. That being said, it was clear from the feedback during the proposed rulemaking cycle that a lot of specialty societies and stakeholders felt they might not be ready for this program. So Medicare responded to that in September by releasing a report that they were going to allow a pick-your-own-pace mechanism of reporting for the first year. It's a ramp-up year. The first year is going to be a transition year made a lot easier, which I'll go through some of the modifications to the program. I'm showing a screenshot of my cell phone on purpose here. This is something I really live on. Medicare has a listserv that can send you updates of what's happening in the Medicare program. They often come at least weekly, but often daily. This was one of the updates I received about pick your own pace. So it allows your practice to be educated in real time so you know what's going on through the regulators. So let's just briefly overview what pick your own pace is going to look like. Basically, there's several different mechanisms you can choose, all having varying pluses or minuses. You can just test the QPP the first year in MIPS, basically by only submitting one quality measure or one improvement activity measure just seeing if you're able to even understand the mechanism. And if you do that, you're going to protect yourself from any downside adjustment in your income. You could also try to participate for a shorter period of time, for example, let's say 90 days, and submit across the program to see how well you did. And that would allow you to either receive a neutral adjustment or a positive adjustment. You could try participating for a full year. You could just forego all of MIPS and be in an APM for a full year, or you can just take the maximum penalty. So let's dive deeper into MIPS. Merit-based incentive payment system. This is the system that most radiologists are going to be on, at least for the first performance year. And those radiologists in MIPS will be called eligible clinicians, as will any other clinician. EC is short for eligible clinician, and that's what the QPP will label us. So what does MIPS look like? I already told you that one of the things MACRA did is it consolidated the current year programs, current quality programs, and those are on the left of your screen, the Physician Quality Reporting System, Value Modifier, and Meaningful Use. What we see on the right is the renaming of these systems in MIPS, and there's obvious parallels. Physician Quality Reporting System becomes quality, Value Modifier becomes like cost, Meaningful Use is being renamed and rebranded as Advancing Care Information, and then there was one additional program called Improvement Activities, which I'll go through later. There is a substantive change I do want to mention here that I think is quite important. Remember I told you the Physician Quality Reporting System was a reporting rate system. You really just had to report a measure, not actually perform. And that value modifier introduced this concept of performing on a quality measure. Also in value modifier were cost measures that Medicare calculated for you based on your claim. Well, when we move over to MIPS, both reporting rate and performance rate fall under quality, making it extremely important for those listening here to understand how it is to perform on a measure. And that is one of my concerns, because the value modifier program, even though it was legislated in 2010, it's been slowly phased in. And to date, in 2016, groups under 100 have not faced the consequences of not knowing how to perform on a measure. And that is going to come to fruition shortly. 2017 we'll have adjustments for the value modifier program for groups under 100, but more importantly, in MACRA and in MIPS, you're going to have to perform well in order to receive a high quality score. The value modifier no longer has a performance rate, so all it has is administrative claims data, meaning you really don't have to report anything for cost except for just submit your bill. So that brings to me, well, how do you even submit data into this program? Well, there's several different mechanisms in several different ways. The broad concept is that you can report as a group, where you can consolidate your measures, and this can certainly ease the burden of reporting. Or you can report as an individual. Just so you know, there's pluses and minuses to both. In general, group reporting tends to be easier. However, there are pluses and minuses to both, which I'll try to touch upon as we dive deeper. I do want to point out to you that whether you report as an individual or a group, the top three mechanisms are all the same, and you can do it either a group as an individual. The middle mechanism, administrative claims data, is just Medicare calculating certain measures on you or certain cost measures. And then the bottom one on the individual claims is very common in the radiology community now, because billing companies often perform this task for you. This is going to be probably phased out and becomes fairly unfavorable under MIPS, and I do recommend that you try to find an alternative mechanism as time goes on. I want to go back one slide here. And the bottom one on the group side, CMS web interface, groups more than 25, is really for multi-specialty groups, or some ACOs require that mechanism. So here's the real benefit that happens under MACRA and how things become easier when the programs are consolidated. Medicare is now allowing you to submit data through the three performance categories that you need to submit data, which are quality, advancing care information, improvement activity, via the same mechanism. So if you use one of those top three mechanisms I pointed out on the previous slide, QCDR, your electronic health records or registry, you basically can submit data across all three performance categories. And remember, cost doesn't require reporting because it's calculated based on your bill. So what happens once you submit data into these performance categories? Well, Medicare will calculate what they call a final score on how well you did on each of your performance on each of these categories. The final score will be a number between 0 and 100. It'll be applied to your first adjustment year, which will be 2019, but based on your performance in 2017, as I stated earlier. So what does that mean? Well, I'm going to show you 2021 adjustment year because, like I said, the first couple of years, the first 2 years are a phase-in. So I want to show you what this program looks like fully phased in. And that's in 2021, which would be a 2019 performance year. Quality would be worth 30 of the 100 points. Cost would be 30 of the 100 points. Improvement activities would be 15 of the 100 points. And advancing care information would be 25 of the 100 points. Essentially, in each of these categories, you'll have a sub-score. For example, they'll calculate a quality score for you. Then they'll multiply it by 30 points divided by 100 points to come up with your fraction of your quality score. What does this program look like the first year? Well, Medicare decided that cost wasn't going to be a category people were going to be judged on the first year. They want people to get used to that notion, and they want people to receive feedback on how they're doing on cost before they actually hold you accountable. So this is what the program will look like for the first year, where all of the cost points are going to be redistributed to quality. I do want to point something out on these last two slides that you may have caught, and that is this terminology patient-facing. Because what I've just shown you is a breakdown of points for a doctor who is determined to be patient-facing. Well, why do we need that language? Well, when Medicare was making this rule, they realized that a category like advancing care information, which had a significant amount of patient interaction in order to accomplish the task, was probably not going to be achievable, or at least easily achievable, by doctors who might not have a lot of patient-facing encounters. So they needed to make some concessions in this rule for that. Additionally, improvement activities, Medicare didn't necessarily come up with a lot of improvement activities for these non-patient-facing doctors, which they'll refer to these doctors in the future. And so they had to make some adjustments to the improvement activities category. And like I said, pathologists and radiologists will be probably considered non-patient-facing doctors on the individual level, but we'll dive into that deeper in just a second. They had to make these special considerations for these types of doctors. They also made some special considerations for rural doctors. Now, how is Medicare going to define a patient-facing versus non-patient-facing doctor? Well, in the proposed rule, Medicare basically said that they're going to use 25 patient encounters as a limit. If you have 25 patient encounters that are patient-facing, based on the type of CPT code you're billing, you would be considered patient-facing whether you bill as an individual or a group. The problem is they didn't quite tell us what the patient-facing CPT codes were. They could have been anything from zero-day global surgical codes such as paracentesis and thoracentesis to the more complex surgical codes or the evaluation and management services, or it could be some type of permutation of these. So what we did at the ACR, especially, and using the resources that we have with the Harvey Neiman Health Policy Institute, led by Danny Hughes, is during our proposed rulemaking letter, we decided, well, we need to come up with a threshold that makes sense for our membership. And we studied a 2014 claims file, and we came up with a number of 100 patient-facing encounters. And that could be defined any of the ways that Medicare was thinking about either E&M, 10 and 90, or zero-day global. And what we found is that we increased the number of doctors that could receive these special considerations in the radiology community quite a bit, from 72 to 88% if you included all three types of encounters as patient-facing, all the way up to almost 100% if you just included E&M services. And that's exactly what we recommended in our proposed rule letter, that Medicare use 100 patient-facing encounters and that they'd only define it as E&M services. Medicare subsequently in the final rule accepted the 100 threshold, but we're still unclear of what codes are going to be considered patient-facing. That should be released any week now, which would provide clarification for our entire membership. Medicare also extrapolated and allowed concessions for group reporting in here. Originally, they recommended groups also had to have the 25 patient-facing threshold. In the new rule, in the final rule, Medicare's changed that. So as long as 25% of your members, or as long as only 25% of your members in your group are patient-facing, you could still be a non-patient-facing group as long as 75% of your members are non-patient-facing. So let's look at the non-patient-facing distribution of these performance categories. With non-patient-facing designation, you actually will be exempt from advancing care information. Advancing care information points will be distributed into quality. And that's for when the program's fully phased in 2021 for 2019 performance year. Well, how about the first transition year, 2017 performance year, 2019 adjustment year? Well, you also won't have to be judged on cost and advancing care information, and all the points get moved up into quality, meaning for a non-patient-facing clinician, potentially like a radiologist, quality is a large portion of your final score, meaning you really have to perform well on your measures. So eventually you will receive a final score. Medicare will pick a performance threshold based on every clinician in the country's final score. It'll pick a performance threshold that may be a mean or a median. And if you fall below that mean or median, you would get a negative adjustment to your income. If you fall above it, you'll get a positive adjustment to your income. And the adjustments range from 4% in 2019 all the way up to 9% in 2022. I'd like to say that this is a pure income adjustment, but it's more complicated than that. I'm not going to go into the deep nuances of this, but essentially this is a budget neutral program. And what that means is that the winners take from the losers, and there is no other taxpayer dollars being added to this program. So Medicare, in order to keep the budget neutrality of the program, had to multiply the adjustment factor, which I talked about in the last slide, by a scaling factor, which could be anywhere from 0 to 3. And if that scaling factor is 3 and the adjustment factor is 9% when the program's fully phased in, the upside's up to 27% of a positive adjustment in this program. So it all depends on how the performance rate is and what the scaling factor is. To put this in perspective, the first year Medicare has arbitrarily chosen a very low performance threshold of 3. What this means is very few people will actually fail this program except for those who completely fail the report. But that leads to a very low scaling factor of less than 1. So less than 1 times 4% adjustment factor first year will lead to bonuses that are very small, probably under 1 or 2%. There is a super performer bonus that's also given, but even with that, we probably won't see anywhere near the adjustments of positive 4% in the first year. So yes, this program has a risk of money. You definitely have money at risk, but you also have your reputation, because your performance score, as well as individual measures that you submit to Medicare, will end up on another Affordable Care Act mandate to increase transparency to its beneficiaries, is the Physician Compare website. Those quality measures and your score will end up on this website, so beneficiaries can look you up and see how you've performed on the programs. So in essence, they can shop for a doctor or a hospital, because there's also a hospital equivalent website. So let's dive deeper into some of these categories in myths. Let's take you through quality. In quality, you're going to be required to submit 6 total measures, which should include 1 outcome measure if available. You have to report at least 50% of your Medicare patients if you're in claims, or all payer if you're reporting any of the other mechanisms, the top 3 mechanisms I pointed out earlier, QCDR registry or EHR report. Each measure is worth 10 points, and the points are divided up by deciles. So if you ended up in the 50% decile, you would receive 5 out of 10 points in this category. There is a 7th measure that should not apply to radiologists called all-cause hospital readmission measure. This is calculated by Medicare. We are finding through this year's feedback reports on the value modifier program that some radiologists are being attributed patients to this measure, and we think it could be because the Medicare provider enrollment supplier type that the groups register under could be incorrect. They could be registered as a group practice or clinic, and they should switch that to other radiology so that you don't have this measure attributed to you. So how can ACR help you achieve a high score in quality? Well, remember I showed you the reporting mechanisms earlier? I want to highlight one of them, and that's QCDR. I want to point out that this is called the Qualified Clinical Data Registry. It's totally different from a qualified registry. That's a very common confusion here, that this is a different entity and it should be treated as such. And many people think they're in one, but they're actually in a qualified registry. What is a Qualified Clinical Data Registry? Well, this was an entity created by the American Taxpayer Relief Act of 2012. And this is the definition provided by Medicare. It basically is an entity that can help improve care or track disease. Why am I making a big deal of this? Well, I'm actually not making a big deal of it. The legislation itself, this is straight from the statute. The lawmakers actually want the Secretary of Health and Human Services to encourage the use of these in MIPS. And this is, again, a screenshot right from the law. So how did Medicare respond? Now, this is a screenshot from the final rule. I won't read the whole thing. But in essence, what it says is if you use a QCDR, you're going to have a lot more measures to pick from. The improvement activities you have to do, some of them can be done through your QCDR. And in fact, you can submit data across all the performance categories you need to submit through into MIPS through QCDR. So it provides a lot of power. And in summary, I'll just point out the last line, that Medicare believes by allowing those flexible options that you could positively affect your composite performance score by using these entities. And I agree with that. So guess what? The ACR does have a QCR, and that's the National Radiology Data Registry. That's a collection of data registries that colleges had since at least 2008. They can be disease-specific or specialty-specific or modality-specific. They include lung cancer screening registry, our dose index registry, a general radiology index registry, as well as our mammography registry and colon cancer registry. The interventional radiology registry, which you see in your lower right-hand corner, should be launched shortly as well. What's in these registries? Well, there are some process measures to make sure you're doing things correctly. For example, measuring the carotid stenosis properly or sending out mammogram reminders. But there are also outcomes measures on how well are you performing or how well are you actually reading a study. So, for example, your true positive rate in detecting colon cancer on a CT colonography, or your cancer detection rate in lung cancer screening. Now, this is an important slide. I want everyone to remember this. The mechanism you choose to report into MIPS matters. Why does it matter? Well, if you use one of the electronic reporting mechanisms and you capture your measure electronically and submit it to Medicare or your QCDR electronically, you can receive up to a 10% bonus on your denominator that's applied to your numerator in your quality score. So what that means is out of the 60 points possible in quality, you can get 6 extra numerator points by just submitting your data electronically. So those submitting by claims-based would not be eligible for this bonus. Also, the QCR by mandate basically has a lot more measures. On the left, you have traditional registry and PQRS. You may have 8 to 14 measures. On the right, you have QCDR. You may have up to 40 measures. Now, we're currently undergoing some measure analysis where there'll be some measures that possibly cut through QCR, but in essence, this will remain. There'll be a drastic difference from the number of measures you could submit in a QCR versus any other mechanism. And then additionally, the feedback you get in a QCDR is much more robust than the feedback you get through many of the other quality programs. So for example, on the left, you have Medicare's feedback for when you submit quality measures through claims-based. This is called a QRUR, Quality and Resource Use Report. I'm showing a screenshot of my cell phone showing on April 20th, 2016, Medicare sent me a reminder that my mid-year 2015 report was available. Well, guess what? That's too late. The reporting period is already over. I can't make adjustments on how well I did on the program. On the right is the NRDR feedback report. It's actually my 3rd quarterly report of the year. It came in November, and it gave me plenty of time to make process improvements on how my practice is doing on these specific measures that we made. And in essence, that's exactly why the legislators and the regulators want to promote this entity. It's because there is this concept of it being cyclical and a cyclical quality process improvement process where you'll receive feedback reports, you'll implement change, and continue to improve. So this is the second most important slide in MIPS I want to show you, and that is the measures you choose to report matter. So this is a screenshot from the final rule. It's in the appendix. I want to highlight a line here that says high priority measures can be marked with either an asterisk or exclamation point or a double exclamation point. Then I'm going to show you several measures in radiology and highlight that they have these exclamation points next to them, and that means they're high priority. Well, what does that mean? A 10% bonus on your denominator again for quality score. So that's a 6 extra points. If the more of these you submit, you can get another 6 extra numerator points. So in essence, if you submit electronically and you submit high priority measures, you already start with 12 out of 60 points in quality without even having a performance rate calculated, putting you at a significant advantage. And yes, there are measures that aren't great to pick either. I'm not using radiology measures here because they're a bit, they're not as transparent as the measures I'm showing here. So here you see benchmark means of a hypertension measure of 69% with a fairly low standard deviation, meaning this measure was probably fairly hard to do. However, there's a lot of upside scoring potential here because if you're 1 standard deviation above the mean, you're probably going to be in the 7th or 8th or 9th decile in scoring, meaning you could get 8, 9, or 10 out of 10 on this measure. meaning there's a large, broad area to score well. As opposed to this measure I'm showing here, which has a benchmark mean of 95% with a standard deviation that includes 100%. This measure is clearly really easy to do. However, if the benchmark mean is 95% and that's the 5th decile, so 5 out of 10 points, to get 6 or 7 out of 10 points, you really have to score much higher than 95%, and it's going to be very difficult to score quite well on this measure. Medicare actually had initially proposed that these really easy measures where the benchmark means so high, they would propose that these were topped out, and they wouldn't even allow you to score 10 out of 10 even if you got 100% on these measures. In fact, they gave an example where someone scored 100% on a performance rate of a measure, yet they only got 8.5 out of 10 because Medicare didn't want people to have this program to pick these measures because they were too easy. Just so you know, that topped-out methodology was not incorporated into the first year, so it's okay to pick these easy measures. However, the scoring opportunities may be very difficult nonetheless. So to put this kind of in perspective about why the measures and mechanisms you choose matter, this is me, and I have 2 different taxpayer IDs. And just to reiterate, this program is treated totally independent of your MPI. It depends on your MPI TIN or your taxpayer or just your taxpayer ID number. So basically what that means is I'm treated as a totally different physician in every TIN that you have, and you can't share patients or share measures across those TINs. So in one of the MPI TIN combos, you can see the claims-based measures I have. The ones in green are high-priority measures where I can collect bonus points. The other TINs on the right, the MPI TIN is on the right, and those are the measures available for me. The ones in black are ones that you just can get the standard amount of points. If you use claims, that's what you have to pick from. If you use a qualified registry, that's what you have to pick from. If you use a QCDR, these are all the measures you have to pick from, showing you the power of picking the appropriate mechanism for reporting. And again, the green ones are all conditions you could potentially score bonus points on. So let's take you through cost. Medicare finalized 3 cost measures for the final rule. Even though cost doesn't apply the first year, in the future there'll be 3 cost measures. The first one absolutely applies to radiologists. It's called the Medicare spending per beneficiary. This is attributed to beneficiaries based on, it's attributed to participants in Medicare based on hospital stays and inpatient hospital stays. So Medicare patients admitted to a hospital, those costs are calculated, and then they're attributed to some clinician that's billing Part B. And how these are specifically attributed is whatever clinician bills the plurality of Part B services. So if your TIN billed the plurality of services and value modifier, this measure would be applied to you. So we see lots of radiology groups having this measure attributed to them. Now the attribution methodology changes a bit under the QPP. Instead of it being applied to your TIN, it's applied to the NPI TIN combo. I don't want to dive too deep into this nuance, but this may have implications on how you report it, either as a group or an individual. But it lessens the number of attributes that could be applied to you. The one issue is that the threshold value for when this measure applies and value modifier was 125. So you had to have 125 patients attributed to you before this measure actually applied. In MIPS, it only has to be 35. So this measure probably will still come back to haunt radiologists in the MIPS program. There's also a total per capita cost measure. This should not apply to radiologists, again, if you are the correct supplier type, which is other radiology and not group practice or clinic under your Medicare provider enrollment. This measure should not apply to you. It could potentially apply to radiology groups with PAs or NPs that unfortunately are registered as group practice or clinic, and again, those groups specifically switch to other radiology under their supplier type. And then finally, the third way cost could be measured is these episode groups. Medicare finalized 10 different procedure episodes, and how these work is there's a set of trigger codes and relevant services and sequelae services that are used to calculate the cost of, let's say, a hip replacement. And then that cost is compared across the country. Now, these are more targeted ways to determine how much a participant in Medicare is using resources. And they have to be assigned in a specific way. And the attribution methodology is actually new. They will be assigned based on patient relationship code. This is a new concept under MACRA, in which when you submit a Part B claim in the future, you'll have to determine what's your relationship to the patient. So in essence, Medicare can assign an episode group to that specific claim. These codes are in development now, so they're not available at this time. So how does ACR help you in cost? Well, certainly everyone should know about the clinical decision support module that helps make sure that the ordering clinicians are ordering appropriate imaging. There's also the RScan initiative, which is also very tied to appropriate imaging, in which there are white paper-based imaging paradigms based off of choosing wisely, and RScan gives you a set of tools to interact with clinicians to make sure they're ordering appropriate advanced imaging. Just so you know, RScan is now being co-branded with a similar initiative in the emergency world. The American College of Emergency Physicians has an initiative that also looks at advanced imaging in the emergency department. This is a neat way to partnership with your emergency room, and it's something I've done in my practice where we're actually using the clinical decision support data in a registry to benchmark clinical decision support scores. We're tying it into a registry feedback on how our ordering doctors are doing. We're adding in RScan and the Equal project from the American College of Emergency Physicians, and we're working as a team to make sure that the advanced imaging through our emergency department is ordered appropriately in the appropriate situation. What about our role in cost? Well, there's certainly some measures in the quality category that look at our costs, making sure we recommend appropriate follow-up for thyroid lesions and abdominal lesions. I'm not going to dive any deeper, but following appropriate follow-up paradigms is one way we can control cost on our end. And certainly the product ACR Assist can help go a long way doing that, where it's a decision support for the radiologist in which standard recommended follow-ups are at your fingertips in an electronic format so that you know exactly what to recommend and not cause too many downstream costs. So advancing care information, I don't want to dive too deeply into it because most radiologists will be exempt from this, but there will be radiation oncologists and intervention radiologists that will have to perform in this category. In essence, there are 6 objectives in this performance category. These are the objectives. And then within each of these objectives, there could be measures. And when you expand this out, here you have on the left here all the objectives that I just showed you. Then you have measures associated with these objectives. And in essence, you have to get a base score and a performance score. The base score is achieved by either replying yes or no to several of these required questions, like do you protect patient health, or scoring at least a numerator of 1 in the required elements. For example, in the health information exchange, send a summary of required. Did you at least have a numerator of 1? If you do this for the 5 measures inside the base score, you will achieve a 50% out of 100. And then you need 75% to pass the program and 100% in order to get full credit. And the way you get full credit is based on your performance in all these categories listed here under the performance score. Basically, you have to have a numerator and denominator score, which will give you a performance, and they have to be added up so that you get to at least 100 points to fully achieve the program. There are bonus opportunities in this. For example, if you submit to QCDR, you could get bonus points. If you report improvement activities, which is the last performance category I'll go through, if you report improvement activities using electronic health records, you could also get bonus points in advancing care information. So the final category is improvement activities. There are 9 broad domains, but 90 activities inside them. What Medicare has done is, it's because non-patient-facing clinicians didn't have as many opportunities for activities, it's allowed them to do essentially half the number of activities to receive full credit as a patient-facing clinician. There are high and medium value activities, and you basically have to either do 1 or 2 as a non-patient-facing doctor or 2 to 4 as a patient-facing doctor in order to achieve full compliance. Some activities in here are achieved by using the Qualified Clinical Data Registry, which is our NRDR. RScan is also a high value activity, so if you're using RScan, you actually fully comply. You get 100% of this performance category right off the bat. So I want to bring home QCR reporting to you before I jump into APM. So it's December 31st. You're about to report your quality measures to Medicare. The good part about QCR reporting is that you don't have to report until the performance year is finished. You sit down in front of your portal, all the measures, and if you were smart, you collected as many measures as possible, possibly up to 40. All the measures are right in front of you. You have your reporting rate and performance rate. and you can literally handpick the measures you did really well on. You can handpick high priority measures, and you can handpick measures that you might not care that went online and that patients could see that aren't necessarily politically sensitive. In essence, you're maximizing your final score and you're protecting your reimbursement and your reputation by hand selecting these measures. That being said, Medicare has said that it can help you select measures. So if you don't understand this process, you can just submit as many measures as you want as long as they meet the performance threshold, and Medicare will choose the measures you scored the highest on to give you the highest final score. So let's switch to the alternative payment models for the last few minutes of this talk. Well, why would anyone want to be an alternative payment model? Well, first off, if you're determined to fully satisfy the criteria, meaning you're in the correct alternative payment model and you're meeting the threshold to be an alternative payment model, you automatically receive a 5% aggregate Part B bonus every year from 2019 to 2024. So there's a positive upside no matter what, as long as you are qualified for this program. Additionally, starting in 2026, the update to your conversion factor, which is the amount you're paid per encounter, goes up faster than it will under MIPS. It goes up 0.75% as opposed to 0.25% for MIPS. So certainly there's a financial upside for being in APMs compared to MIPS. There's also the MIPS headache. If you didn't get a headache from the section on MIPS I just described to you, I'd be shocked. In APMs, the reporting requirements are significantly easier, getting rid of this kind of tournament style of reporting. Like I described to you earlier, unfortunately not everybody participating in the APM will qualify for this upside bonus and relief of headache from MIPS. And that's because of this strict criteria Medicare has put forward on what actually qualifies a person to be considered a QP, meaning you're eligible for that bonus or you're eligible for not reporting the MIPS. So here you have is a chart. Somebody who's called a qualified participant is somebody who, on the bottom here, you can see, is in the correct APM model, which now are termed advanced APM, and you meet the correct QP threshold, meaning you have a significant portion of your payments or your patients that are going through this APM entity. If you meet these criteria, you'll be called a QP, you're eligible for the aggregate 5% bonus, you're eligible for the higher fee schedule update, and you're no longer reporting into MIPS and have gotten rid of the MIPS headache. Now there's an in-between territory where you're called a partial qualified APM participant. These are people who might be in the correct APM model, or they have to be in the correct APM model, which is an advanced APM. However, they don't quite meet the correct QP threshold, but they meet a lesser threshold called the correct partial QP threshold. What these participants get is that they're exempt from the headache of MIPS, but they're not eligible for the 5% aggregate bonus or the increase in the fee schedule. So there's some benefits for being in this, but not quite as many. And then finally, there's a group of doctors who participate in APMs that might be in the correct APM model or an advanced APM, but they don't meet either the partial QP threshold or the QP threshold, or they're just in an incorrect APM model, an APM model that didn't meet the statutory requirements of being an advanced APM. These clinicians are called MIPS APM clinicians, or MIPS. They're basically MIPS eligible clinicians, but they're in MIPS APM, and they unfortunately still have to compete in MIPS. They're not eligible for the aggregate Part 5% bonus, and they're not eligible for the adjusted fee schedule update, but they do receive favorable status in MIPS. What are the advanced APM standards? Like I said, not all APMs are considered advanced APMs. Well, under the statute, you had to have quality measures, you had to have certain cost measures, and you had to use advanced technology in order to be considered an advanced APM. As you know, this is very similar to MIPS. It doesn't have improvement activities, but in essence, improvement activities are considered part of these in an APM. So let's dive through these advanced APM categories in more detail. So in the quality section of APM, in order to be considered an advanced APM, you have to submit measures that are equivalent to MIPS. Some type of quality measures are equivalent to MIPS. The financial risk, you had to have more than nominal financial risk, and Medicare finalized that as being either a revenue-based standard or a benchmark-based standard, which I won't read to you. You can see on the screen. And finally, the advanced APM entity had to have at least 50% of its clinicians using electronic health records technology. Didn't necessarily have to report into these base and performance scores I described in advanced care information, although some of the APM models do have some requirements in reporting. But in essence, all you really had to do was make sure you're using electronic health records technology, but not necessarily reporting in that robust way as you have to admit. So which models actually met these three base criteria? For the first year, these are the ones that are there. I'll point out some glaring absences. One is the Medicare Shared Savings Program Track 1 did not meet the advanced APM criteria because it didn't meet the financial standards. There's also the Bundle Payment for Care Improvement Initiative didn't meet this because there's some lacking some quality measures and some cert requirements, and so it didn't meet these requirements for the first year. Subsequently, in August, Medicare realized that many of its episodic payment models, for example, the bundle payment and the comprehensive joint replacement, which are all kind of bundle payment models, they didn't meet the advanced APM standards. So Medicare decided to create a rule where they'd effectively retrofit these models so they could meet the advanced APM standards. And that's what's going to happen in year 2. You will see that we're going to have these new voluntary bundle payment models that are going to meet the APM standards. We're also going to have these EPM models, such as a comprehensive joint replacement model, that will meet it in year 2. And also, what was interesting in the final rule is this Medicare Shared Savings Program Track 1, although it didn't meet the financial standards, it appears that Medicare is going to adjust that program to create a new track called 1+, which probably will have some financial risk, but will allow participants to become QPs. And in the future, we expect there to be all-payer combinations and intermediate options where you'll be able to add in private insurance companies to try to meet the threshold value. So that's the first criteria. You had to have the right model. The second criteria was you had to have the correct amount of either payments or patients in order to be considered a QP. And these are the escalation of how that works in the first performance year, which is 2017, and the first adjustment year of 2019. You have to have 25% of your Medicare payments coming through the advanced APM entity in order to qualify as a QP, and that escalates to 75% by 2023. There's also a patient attribution model in case you didn't make the payment model that you could also apply. Then there was the partial QP APM participant model where the thresholds are slightly less, but you still had to have a certain percentage of your payments or patients in that model in order to be a partial QP and be exempt from MIP. So what's at risk in the APM model? Well, you also certainly have your risk online for all the beneficiaries to see and judge how you did compared to other ACOs in your area and clinicians in your area. And obviously there's a financial risk to being APMs as well, but clearly there's also the benefit of not having to report into MIP, the headache of MIP, and the financial risk is at least buffered a bit the first few years because of the aggregate Part B 5% bonus. So in summary, how people would be participating in QP is most people will probably be a MIPS eligible clinician and be fully a MIPS and be called an EC. Some people might be in an APM and either be in the right model with the wrong threshold or in the wrong model, and they'll still be in MIPS and they'll be called eligible clinicians or ECs, but they'll have favorable status in MIPS. There's also, on the right, the qualified APM participant or the QP who will be eligible for the Part 5% bonus, the updated fee schedule, and not be in the headache of MIP. And then there's the partial qualified APM participant, which won't have the upside 5% aggregate bonus, but won't have to report into MIP. So most doctors are going to be in one of these categories. There's one I didn't mention, and that's those clinicians who bill Medicare at a very low volume threshold, either patient volume or cost volume, aren't in any of this. They're not in the QPP at all, and those are called not eligible for QPP or low volume threshold clinicians. They will continue to receive fee for service. It's a minority of physicians, so very few doctors will be in that category. So the last construct in MACRA that I wanted to touch upon on just one slide here is this notion of that a lot of specialists don't have alternative payment models to participate in. And the legislators realized this, and they decided to create this entity called the Physician-Focused Payment Model, in which they're targeted models where specialty societies or stakeholders to create scenarios in which they can improve the quality of care and reduce costs and come up with a new model that would pay value over volume. And this, Medicare would consider that as being possibly an advanced APM if it met all the advanced APM criteria. In order to handle the submission of these new physician-focused payment models, They created a committee, the MACRA law created a committee called the Physician-Focused Payment Model Technical Advisory Committee. This committee will start receiving applications from stakeholders in December about different models that specialty societies are thinking of promoting. PTAC will evaluate them and determine if they meet the criteria for being an alternative payment model. They'll then work with the CMS Innovation Center to determine if there could be advanced APM models and qualify somebody as a qualified participant. Now, I want to reiterate, change gears here just a little bit, that although I've talked just about Medicare, there's no doubt when you read the final rule, there are numerous statements about how Medicare wants to make this entire program, whether it's MIPS or APM, translate into the private world. And we're certainly seeing all sorts of public and private partnerships pop up all over the place, trying to homogenize the healthcare system. For example, one of the problems was quality measures in the private world could be different than Medicare. And in 2015, Medicare joined with the American Health Insurance Plan to start unifying the quality measures. And we saw that news release in 2015. We also see organizations that are pseudo-governmental, governmental, and private partnerships. For example, the Learning Action Network that develops white papers and strategies on how to convert the population of clinicians out of fee-for-service into alternate payment models. And this is an interesting entity because there are over 200 participants in this, ranging from drug companies to universities to private insurance plans to Medicare staff that come up with these think tank papers. Private insurers are also getting into the game, creating limited networks. There's also third parties out there that are trying to get into the game. For example, this is a company in the New York, New Jersey area that actually called Spremo that actually looked at the quality of the radiology report to determine if they're a high quality practice, and they try to shift their patients to these high quality practices to see if they can reduce costs. I want to end on this slide here. This was an enormous amount to absorb. I'm glad we're doing it in a webinar format so you can go back and listen to it so that you parts that you didn't catch, you make sure you hear it more than once. This will all end up on the front page of the acr.org website. If you go to the MACRA tab, this webinar will be there for you to look at over and over again. Also, there are a number of resources under this MACRA tab, including our rule letters and many different instructional videos on how to make sure our membership is successful in this program. And I want to thank you for your time, and I hope you enjoyed listening.